Okay. All right. So HM2 Lamson here with HM2 TJ and HM1 DiBiase. Okay. So I'm here to present the shoulder exam. So always the first thing you have to ask is your vitals. Okay. Your allergies, any medications, any tobacco or any alcohol afterwards, and what do they call this? They weren't saying anything about mechanism of injury right here, but it's nice to actually identify, just in case, mechanism of injury. Now we go for the shoulder. So now for the inspection, we want to make sure that we're actually looking everything symmetrical. So if you don't mind if you...
Oh, 1 minute.
Yeah. Don't worry, don't worry. It'll be better if you could actually see things symmetrical. So, okay, there we go. And release. Okay, so we're back again. So making sure that we're looking at shoulder contour, we're checking at symmetry. Okay, making sure that there's no crepitus, there's no broken deformities that we could easily see. Okay, skin and subcutaneous tissue, making sure that they're actually pretty much symmetrical with both as well. And then your glenohumeral rhythm, this is done also either sitting down or standing up. So go ahead and stand up for me, sir. Okay, and then this is done also by viewing the patient from behind. So go ahead and face the wall. Okay, so what I'm be doing is first, assuming that the patient already knows what I'm doing, go ahead and follow this. So go ahead and take your hands towards your sides, outward. So adduct, adduct. Okay, good. Palm up, and then go all the way up. Good. And then what you're trying to observe here is the movement of the scapula, making sure that the scapula does not lag. So as you come back down, you want to see that it actually follows through afterwards. There we go. And then relax. Okay. And then go ahead and take a seat. Okay. Now, upon close inspection, we could go ahead and check for the scapula, for the scapulas right here. Okay. So the clavicle, making sure you start here from the manubrium. Okay, you got your sternoclavicular joint, which is the combination of your sternum and your clavicle. You want to move medially, or from medial to lateral. Okay, and then at this point right here is going to be your AC, the combination of your clavicle and your acromion, hence the word AC joint. And then from here, okay, you're going to go ahead and palpate. This is your acromion. Okay, if you move more lateral and medial following this, you're going to get to the spine of the scapula. So go ahead and come this one. Okay. So spine of the scapula is right here. Okay. You got your supraspinous fossa. You have your vertebral border, or the medial border of your scapula. You got the inferior angle of your scapula right here. You got the lateral border of your scapula. Come back this way. Okay. And then from here, okay, right underneath your acromion is your supraspinatus muscle. Okay. And your supraspinatus is inserted at your greater tubercle, just in case. There's 3 out of the 4 sits muscles that insert right here. You got your supraspinatus, infraspinatus, teres minor. The only thing that's inserted at your lesser tubercle is your subscapularis. So 3 out of the 4. Now next is, from here you have your subacromial space, hence the word acromion, sub underneath. Okay? And then from here, you want to go more medial, just a tad bit, and this is your bicipital tendon, and then in between this is your bicipital groove, which is the formation of your greater tubercle and your lesser tubercle. Okay, and then proceed more medially, right here. Okay, once the patient would most likely complain of tenderness, you're actually at the coracoid process. Okay, so from here, I'm going to go ahead and trace the shaft of the humerus, just in case if they need to identify that. Okay, you got your deltoid insertion right here, or deltoid tuberosity. If that didn't come out, don't worry about it. Okay, so let's see, what do you have? You have here in your sheet. Okay. All right, that's it. That's for the bony prominences and the muscles. Next is for the range of motion. So we could have the patient stand up. Okay. Now you could go ahead and face him. Face the camera too as well. Okay. Now forward flexion. Okay. So ask the patient to bring his hands forward. Okay, all the way up. Good. And then come back down. And then this is coming back to extension and hyperextension, which is all the way towards the side. So go sideways, side profile. Good. Come back down. Come like that. Good. Now go ahead and face back again. Now you want to observe again his abduction and adduction. So go ahead and do your abduction. Take your hands outward, palm facing up, going all the way up, and that's your abduction. And taking it back in is your adduction. Good. Now go ahead and face back towards me. Now go ahead. There are two ways to do your external and internal rotation. One is what they taught in the PCL. Go ahead and do this number right here. This is your external movement, okay? And then reach back here is your internal rotation, okay? Second way to do this is having the patient have his shoulder and elbow in this position. Go ahead and take it in. It's your internal. Go ahead and take it out. It's your external. And then let the patient perform a shrug, a shoulder shrug, and then come back down. Next is the muscle testing. So oppose everything that you told the patient to do. So hold this. This is the most prime position to test almost everything. So what you want to do now is resist shoulder flexion. You could tell the patient, okay, go ahead and move, bring your shoulders up, fight that, good. From here, you could go from extension, go ahead and pull back, fight my hands, good. Then go for abduction, go this way, and then adduction, fight my hands, good. Now, internal rotation, everything's perfect. Internal, fight my hands, good. And then external rotation, fight my hands. And then lastly, shoulder shrugs, go ahead and shrug, and come back down. Good. So after all the muscles have been tested, now we go for the special test. So the first test that we have is the Mears test. So the way I remember this and would actually help is think of the far part of your hand going near. That helps. So you want to actually have the patient internally rotate the shoulder, okay? And then you actively bring it up. And the patient would complain of pinpoint tenderness at the insertion of the supraspinatus. Okay, so that's indicative for supraspinatus impingement. That's number one. Next, I'll move this way. Stay this way. Now, next is going to be Hawkins. So you have the patient abduct to 90 degrees, and then what you want to do is actively internally rotate the shoulders this way. Okay, and you're testing for supraspinatus impingement too as well. Okay, come back down. Next is going to be apprehension test. Okay, good. So this is done basically supine, but just for demonstration purposes, we'll have the patient standing up. So assuming that the patient's actually laying down, you want to actually abduct, okay, and then you want to externally rotate the shoulder. A positive sign would be the patient having this side of the shoulder, having it go forward. So forward or anterior translation of the head of the humerus over the glenoid fossa. Okay. Next is going to be your sulcus sign. So sulcus sign is just pretty much just grabbing the medial and lateral epicondyles, and then just do a quick tug. If the patient does this, go ahead and support here at the other side, and then just do this. What you want to observe is what you call a sulcus or a divot or a shadow casting over this section of the shoulder. Jerk test would not be included, so don't worry about it. Next would be Speed's test. So this is done. Go ahead and face towards me. Okay. Here we go. There, that's good. So go ahead and do this number right here. So Speed's test is pretty much checking for shoulder flexion or biceps flexion. So this is at the patient's position of testing. So all you have to do now is just resist this. Okay. So the patient actively goes up. All you have to do is just resist. Okay. Positive sign would be pain at the bicipital tendon area or the bicipital groove. From this point, you could let the patient come to a Y position, and this is for your Jurgensen. So what you want to tell the patient is just continue doing elbow flexion, okay? Elbow flexion. What you, the provider or the tester would be doing is resist, elbow flexion, and externally rotate. So go ahead and do this, pull it up, pull it up, pull up, pull up, and then I have to take it out, okay? A positive sign would be subluxing off the biceps tendon over the bicipital tendon. Okay, and pain also at the bicipital tendon too as well. Next, empty can would be next. So empty can would be testing for your supraspinatus too as well. So from here, you could take the patient here from the horizon 180 minus 60, approximately about 60, and then let the patient sustain this. You as the provider would put a downward force. Patient would complain of tenderness or pain right here at the insertion of the supraspinatus. And that's indicative for your supraspinatus impingement. Relax. Relax, relax. Okay, good. drop arm test next is pretty much the safest way to do drop arm is this way. So if you're suspecting that the patient has drop arm, make sure that you guide the patient on abduction, okay? And then tell the patient to sustain this position for a while, and then slowly take the arm down, all the way down. The last 10 to 15 degrees off adduction, the patient would give in, and that's an indicative of